Good afternoon. I am honored to be part of the session of screening strategy for Central and Eastern Europe. I do regret that I am not being able to participate directly at this meeting online, and I hope that this presentation will help in sustaining the screening strategies, the most effective one for our region. I declare no conflict of interest, and in this presentation, I will start with the human brain and the balance between the human brain and heart in development of the fetus. It's the key of the health of the offspring and the weaknesses of the maternal health and adaptation during the pregnancy, because the special development in the human brain, which starts very early and ends after the delivery, it is a marker of all the disturbances during the pregnancy, and it's an example for the preeclampsia harm during the pregnancy and in long-term studying. The term of cardiometabolic disorders, it is, I can say, the problem of the nowadays health in all over the world, and the epidemic of obesity and glycemic disturbances related to hypertension, lipid regulation, impair the pregnancy's outcome in a population with cardiometabolic problems disorders as a social problem. And the results related to cardiometabolic adaptation shows us that the sex-specific or gender risk are different from this point of view. The women have a lot of protective passages before pregnancy, after the pregnancy, by their hormonal environment, and especially during the pregnancy, which can be unfortunately overpassed. And that's why the new research areas probably will cover this sex-specific molecular mechanism and gender influences and helping the therapies before, during, and after the pregnancy. There are the witnesses of the cardiovascular disease all over the world, showing that the acquired heart disease are responsible for most of the maternal mortality in the world, not the congenital heart disease, which by proper surveillance and good therapies might achieve a good a good outcome. Older maternal age and relation with the disturbances in the lipid metabolism, glycemic metabolism, obesity, and hypertension result of all of this may be a part of the risk, of the social risk related to pregnancies and pregnancy outcome. And preeclampsia, it's one of the disorder which find the risk in all of these problem disturbances of the cardiometabolic diseases. There is also disparities related to where we are living, in low or middle income countries, or we are living in Europe and Africa, ethnic disparities, and the social environment, and not only this, but also the political, and I would say here the political health issues and the money involved in surveillance and in treatment, and not the last in diagnosis of the problems in pregnancies, reflecting the maternal and fetal outcome at the end of the pregnancies. In 2011, United Nations proposed till 2025 to reduce all the non-communicable diseases by 25%, and half of this 25%, half of these all non-communicable diseases are cardiovascular problems. And that's why the main address of the cardiovascular problems are show up in their program, like prevalence of the smoking, prevalence of the obesity, and they promote that only by measuring and evaluating correctly the blood pressure, systolic blood pressure, the decrease will be 25% in the cardiovascular, approved as it is this line here as a prediction till 2025. We will see if we will be able to achieve this in the environment of obesity and glycemic disturbance increasing in the population and the prediction of the cardiovascular changes. Where we are here We were here in 2017, and we are not farther from here. We have the same maternal mortality coming abruptly. We decrease a lot the maternal mortality, but we are still with a higher mortality, maternal mortality, more above all the other rest of the countries in Europe and Central Europe. We are here together with United States, which is the only state which increases maternal mortality. And here we can say that the effort to predict, prognose, and diagnose cardiovascular disease, glycemic disturbances in pregnancy, and in particular preeclampsia as a cause of maternal mortality and cardiovascular mortality, put us on the same wave to increase prevention, prediction, and diagnostic. And we know that the intervention is very important for the future of the mother, because the nurses study showed us that the stress test made by the pregnancy show us that the women with gestational diabetes and pregnancy hypertension, what we call now gestational hypertension and preeclampsia, are the markers in 8-10 years of the cardiovascular disease. And the woman with preeclampsia or gestational diabetes, the mother of a 10 years old child, can be found in an intensive care unit with a cardiovascular disease as a prediction done by this condition and overpassed of the maternal capacity to adapt during the pregnancy have the as a marker for the future health. And that's why the second trimester and third trimester help us to understand this cardiometabolic environment and put together the example of pre-gestational diabetes and gestational diabetes in the balance and in comparison with early preeclampsia as an early failure, as a pre-existing risk for the maternal cardiovascular response due by placental environment very early in the pregnancy. And we know this, and thanks to extensively research of Professor Nicolaides, we now know that the placenta is the trigger for, at least for the early preeclampsia, and we have a mechanism of prevention of the early preeclampsia with the failure most probably due to placenta by the mechanism of aging of the placenta and also the overpassing of the maternal cardiovascular adaptation in pregnancy, exactly as it is gestational diabetes. Most probably combined these two forms for the late preterm preeclampsia. And again, thanks to the people who are doing research, we now know that we have the PLGF both as predicting factor and as diagnostic factor at the second part of the pregnancy, to going to together or alone with S-FLEET markers as a report. And we are talking in the second trimester because preeclampsia, it is second trimester diagnostic, and we can make this diagnostic by measuring blood pressure with proteinuria, but also all the other organ failures together with the IUGR fetus, which is a failure of development in the compartment in utero. So it is a problem in the second trimester, and FIGO, which covers all the area in the world, help us to make the cost efficiency evaluation, and not only us, but also all the societies by giving us markers and figures from the high income to low income society to use all the clinical measurements, but also the biomarkers in the effort to predict and diagnose complication of the pregnancy. And for me, it was a changing of the presentation because 7 days ago, the NICE established this in a guideline. And this effort of the English Medical Society and put a guideline in which PLGF helped, it is established that may help to diagnose preeclampsia. It's a tremendous help for us, because not ever that we will standardize the care, but also will permit to make assumption and to make decision both of in the risk population and in the non-risk population, or the risk population because they are presenting very late in the pregnancy with a lot of complication. So the guideline present all the tests and all the marketplace with their good and limits and prices and evaluation, and the benefit, the tremendous benefit it in the high risk group population. And we will wait for the results for the multiple pregnancies, and we will wait for the result how many times we can do the test and when. After one test is negative or one test is positive, but the PLGF measurement as a diagnostic test will be alongside with clinical evaluation. And this is of tremendously important, that will help us to add biomarker value to the clinical part of surveillance of the pregnancies. And it showed us that the defensive medicine sometimes we are practicing, it was overpassed in England, and I'm very happy to see this, and I hope we will be also able to overpass the defensive medicine and will not increase early births, not even in our country, just by using the test. The main maternal outcome, it is a very it is influenced in a very good way by PLGF testing and better decision to care, ruling out in and ruling out the risk of the complication for, as we will see, for 1 week or 4 weeks. And for the neonatal results in parrot and in parrot 2 that is going on, I'm sure that will show the benefit in statistical numbers, because in clinical absolute medical evidence it show a benefit when you know 1 week before, and we know how important is the interval of 48 hours in modern obstetric for lung maturation and for fetal outcome, and for staying in the neonatal intensive care unit and non-necessary extraction. Repeat PLGF, it will be again of tremendous importance in current practice to be included in the guideline. Till then, I think that alongside with clinical information, we will see, and the window of opportunity after one test, if it is necessary to be done in the second trimester, I'm sure that the interval before, and we have a recent study which show us at 35 to 37 weeks the benefit of determination by biomarker the risk of preeclampsia. Rule out within 1 week and rule out in 4 weeks. The COMPARE study showed us that the PLGF alone stand as a marker for second and third trimester. The group that will benefit is gestational hypertension. It is a risk for preeclampsia that might be testing. In the guideline, it's one occasion. We will see how and when we will be done. If we will do in the second trimester, I think that the evidence in some tests show us that 35 to 37, it's again a window of opportunity if the gestational hypertension exists, and will be follow up in the second to third trimester in predicting the complication of late preeclampsia. And what about our group of risk? The risk existed in the first trimester, exists for sure in the second trimester. And with the American guidelines and the UK guidelines, we have the same group risk that exists in the second trimester. And the second trimester, we will continue with accurate blood pressure measurement, and we get the fetal growth. And of course, we'll follow up the pregnancy as in non-risk group if they didn't develop any hypertensive problem till now. So the biomarkers alongside clinical will be a tremendously input in the risk groups and in the non-risk group, non-hypertensive persons. And we have the group that is already assigned and the high risk group, but there is 11% or 18% in the they are already taking the aspirin for early preeclampsia prevention, but some of them they will develop preeclampsia, and we have some results that the preeclampsia might be postponed with 2 weeks or with 4 weeks, with 6 weeks. after the date it would appear for the fetal outcome, it's tremendously important, 6 weeks from 20 to 26 or from 24 to 30. But in terms, it is still too early, and that's why the biomarkers will help us to in follow-up and improving the maternal and neonatal outcomes. In the obesity person, they are still obese, and they are shifting from the pre-pregnancy inflammation in the first half of the pregnancy. They are going in the stage of fetal, when the inflammation may affect also the fetal compartment in organogenesis, they will be shift in the inflammatory part of the pregnancy when the inflammation it is a little bit lower, but in obesity will continue. So the fetal growth already established, we don't know that it is affected the placenta and the baby, but the baby, it will be on his own growing curve, and we have to evaluate early at 20 weeks to know a little bit about the impact. And we have some data that show us in the obesity, the babies might be large, but also might be small if the risk of preeclampsia and the fetal development already have an influence. Because in the time of organogenesis and in early stages, we don't need so much of oxygen, and hypoxia, it's not really an impairment, but from 20 weeks and second trimester and third trimester, hypoxia have a tremendous impact on the fetal component. Gestational weight gain, it is something at 20 weeks, it's important, and overweight with more than 6 kilos and obese with more than 5 kilos at 20 weeks will show a limit gestational gain, excessive gestational gain, which may give an independent factor risk for preeclampsia. And looking at the glycemic disturbances, they are in the parallel of the risk achievement with preeclampsia, and the gestational diabetes diagnosis and screening, and even the preconceptional diabetes before gave us a group of risk for biomarkers help in distinguish of the risk of immediately preeclampsia or maybe to repeat that term for late preeclampsia. And this is a Romanian study, Predator, and in the group of reproductive age, after adjusting of age and sex, we remain with 2% of unknown data about diabetes, but with an incidence of 28 of gestation of glycemic disturbances in whole population. So the screening for gestational diabetes established between 24 and 28 weeks of gestation, just for the statistical reason that we will discover most of the gestational diabetes between 70 and 80%. As we are going further in pregnancy, at 36, 37, we may discover 90 or 100% of gestational diabetes, but we may lose the intervention opportunity for treatment, adjustment of the diet, activity, which are the key of the gestational diabetes treatment with diet and lifestyle changes. Maybe the preeclampsia will change also, and we will find a good window of opportunity to do the biomarkers in order to achieve a good prognosis for the pregnancy in the late preeclampsia group by biomarkers. Coming back to the balance and going back to the fetal development, the fetal growth is very important to be evaluated early in the second trimester to be able to see, according with all the definition for differences between small for gestational age and IUGR, to establish if the growth velocity increase, if the growth velocity is normal or decrease velocity, and to establish the fetal well-being in the uterus during the second and the third trimester. And we know that each baby, they may go on their own curve, or they may go on a lower curve, and these may be the markers for the biochemical markers to see if this is the fetal growth velocity from preeclampsia before. So we will benefit from the PLGF marker for preeclampsia along with the clinical condition of the fetus inside of the uterus. And area of concern are the fetuses that they are not achieving their possibilities of growth or optimal fetal growth, but they are not falling down in the 3rd% evaluation. And here we are using the optimal weight, gestational weight. Even we know that the birth weight is just a witness. It's not a result by itself, but it's the result of the fetal environment and the maternal environment during the pregnancy. And the optimal birth weight in our department in 2004, when we did this adjustment on our population, it was 3 kilos and 345 grams, because they had a lower mortality. And this J curve, it's the curve we found in all the population all over the world. And if it is antepartum with a lower mortality, and if it at delivery, it is a little bit lower from 90. It is important, the optimal fetal growth. Yes, we know from the past that when and even Osmond in 1993 showed us in a UK population, the deaths, the cardiovascular deaths in the population, according with the percentile of birth weight, they were the same. And it was the same optimal growth that they have the lowest incidence of cardiovascular deaths, the deaths under 65 years of age, where it's a preventable death. So this risk goes with us over the birth, and the womb may be more important than the home, as it was said by Barker, another English researcher, which we now understand more and more by explaining the cardiometabolic changes during the pregnancy with preeclampsia and gestational diabetes. And in the same cohort, when they adjusted by cardiovascular disease and stroke, they were the same optimal growth curve with a J, and with the lowest risk at the optimal grade between 80 and 90% on the percentage of the fetal velocity. It is the size alone? No, it is also the well-being, mostly in the small babies, but also in the babies that we have to follow up, and in early gestational age, around 24, 26, 32, 34, the Doppler, which are the markers and the witness of oxygenation, will help us to cover the one side of the growth, and the other side are the fuels, and monitoring of the glycemic disturbances in the pregnancy, and assuring a smooth curve will help us to give the baby fuel and oxygen that will permit an optimal growth. Again, what is optimal growth? The optimal growth is also the optimal environment. And in the same way of cardiovascular and metabolic disturbances in pregnancy, they are two models that Professor Lee described regarding the maternal cardiac output and maternal adaptation in the pregnancy. And the fetal growth restriction alone without preeclampsia, they have the same metabolic pattern. So this group for sure will benefit from the biomarkers in follow-up and in prediction, and also in intervention groups. And they will benefit not only for the follow-up of the biomarkers, but also for the changing in the hypertensive way of treatment if there is with high vascular resistance and low cardiac output, or high cardiac output and low vascular resistance. Unfortunately, these are not exactly the parameter that an obstetrician will measure. So this will require a very good collaboration with the cardiology and cardiology department. But what is it in our yard? It's the hypertension, and measure the hypertension, the blood pressure, with the proper devices, with proper cuff, in a proper position after 15 minutes of rest. And this is antenatal care for all the pregnancies. So this is very important to be done very accurate in order to evaluate the normal risk, to make the appropriate measurements and appropriate percentile, and to evaluate the the fetus growth velocity. Because even we have very good intensive care units in our department, if the baby is getting out at 37, 38, they will get more need at 7 years of old of special education needs, 36% at 37, 19% at 38, 9% at 39, compared with 40 weeks. Now, going back to the brain, yes, it is a condition, and the biomarkers will help us to make the difference between the risk of preeclampsia, measurement, intervention, correct treatment, and to go back as much as we can to the normal fetal development. And we know, and we have this study, again, Professor Nicolaides showed us, and I'm sure that he will explain more about the assessment between 35 and 37, even if it is the first or the second measurement of biomarkers, and the result of the report as flicked to PLGF, in order to use it as a stand-up measurement for the pregnancies at risk and the values in non-risk pregnancies. And if we were looking at the fetus 7 years after, we look at the mother, the 8 to 10 years after, and the mother with hypertension, they have a marker in the left ventricle wall, and the marker, and the mother which is hypertensive in pregnancy and its current hypertensive 8 to 10 years, the marker in the pregnancy wall, it is even higher. So these women remain and should be follow up in pregnancy and even after pregnancy, in the postpartum period, in the first 6 weeks for sure, and even 1 year after. And the high maternal mortality in peripartum period related to cardiovascular diseases was observed also in the radiology departments and in the high nuclear and molecular imaging in radiology departments. They show up that a woman with obesity immediately after postpartum with peripartum cardiomyopathy with a good diagnostic survived, and the woman with 30 years old with no problems in the pregnancy show us a spontaneous coronary artery dissection, and with a good and proper radiologic intervention and diagnostic survived. Otherwise, they would have been in the maternal mortality ward. So that's why beyond equality, the woman require extra care in cardiovascular imaging and the extra care for from obstetrical point of view, because you know that the pregnant woman will come in the obstetric ward, and also in the 6 weeks after obstetrical, after the delivery, they will come again to the obstetric. That's why it needs a special education of the in the emergency yard and in OB clinic to recognize the high emergencies. And we just started an intervention with telemonitoring the blood pressure of the woman, all the pregnancies, let's say after delivery, 4-6 months will be follow up, no matter of the maternal complication, and we will see. Again, I'm coming back to the 35 to 37 because here we have this very interesting study, and this plus, it's very important because the screening and the clinical input and cardiac markers will help us a lot. What can we do? In 2023, we need to follow up our pregnancy and to have a very good gestational age. We need to know all the cardiac and all the adaptation of the maternal health in pregnancy, and to know that hypertension may appear in the second trimester, because in the first trimester it is masked by the low resistance, physiological low resistance, and to do the proper clinical adjustment and clinical consultation, to know to do the prevention in the first trimester. And we know that here PLGF is a prediction factor, very good prediction factor near the uterine measurements, and we have an intervention, a very good intervention, which may prevent and delay the early preeclampsia. We have to measure our babies and to make the difference between the babies small and the babies who are restricted. And it is important of this, and we have to use in a very good way the biomarkers in order to have the best result and to show their best benefits for the maternal and fetal part, and by our attitude in clinical practice to prevent late offspring and maternal complication, and to postpone or to treat and to make to allow intervention for the good quality of life. Of course, everybody will die because this is human being, and we have a birth and we have a death. But in between this, by our intervention, we can improve the quality of life.